Hi, my name is Aditi Nimishakavi. My research presentation is about sex-based disparities and heart attacks. So before I get into the main part of the presentation, there's a little bit of background that I like to cover. First is the purpose of my research. I have job shadowed a lot at my local hospital, and something I've recognized is not only in cardiovascular health, but in a lot of different health fields, women often experience greater discrimination and a higher mortality rate from a variety of health conditions. However, cardiovascular disease is one of the largest health conditions. Cardiovascular disease is a global health issue. One statistic I found that really stood out to me is that 1 in 3 deaths globally of women are due to cardiovascular disease. This demonstrates that it is important for us to both improve awareness and find solutions to the impact of cardiovascular disease. The last question I wanted to answer as part of the background is, what are heart attacks? Cardiovascular disease spans a wide variety of diseases, but my research focused on specifically myocardial infarction, which is colloquially known as a heart attack. And heart attacks are when coronary blood vessels, which is the blood vessels in the heart, it is when they get blocked, and therefore the heart does not receive enough oxygen because it is not receiving blood flow. And this makes it difficult for the heart to be able to pump blood to the rest of the body. And heart attacks can lead to other long-term risks and complications for patients, including arrhythmia and heart failure in the long term. So first, I'm going to discuss disparities in the status quo between men and women with heart attacks. It is important to note the common or classical symptoms of heart attacks at presentation. While it is true that men and women have differing symptoms of heart attacks, many of the classical symptoms are the same, and these include things like chest pain and pressure, and chest stiffness and discomfort, which a lot of patients report as a symptom of a heart attack. There's not a substantial difference between men and women who experience these kind of symptoms. One study found that around 87% of women experience these kind of symptoms compared to 89.5% of men, which is not a substantial difference and demonstrates that both men and women experience these classical symptoms. Where men and women do differ, however, is in the associated symptoms that are atypical and not as common. This can include things like epigastric symptoms, which could be like acid reflux or stomach issues. It can include palpitations. It could include discomfort in other body parts like shoulder blades. And women are more likely to have these types of symptoms. They're around 7% more likely to have greater than 3 atypical symptoms compared to men. Next, I want to talk about patient perception of these symptoms. This was a study from 2018 that surveyed a wide variety of patients with myocardial infarction. And there's a couple of things I want to note here in this graph. First is that women and men were equally likely to perceive their symptoms as being heart-related. It's around 55% for women and 52% for men. This will be more important later when I discuss provider perception of symptoms between men and women. The other thing I want to highlight here is that women are a lot more likely to believe that their symptoms are related to stress and anxiety as compared to men. This study found that around 21% of women thought their symptoms related to stress and anxiety, compared to only 12% of men. And this demonstrates that societal perceptions of men and women can affect how men and women perceive their heart attack symptoms. This is important because if women wrongly perceive their symptoms to be not heart-related, it can lead to women delaying seeking treatment, which can cause heart attacks to have even more devastating impacts. I want you to take a second, maybe pause, and try to guess how many hours post-heart attack that women seek medical attention. This study found that it's around 5.4 hours, which can be a significant difference in receiving like life-saving treatment that is able to help women overcome heart attacks and prevent the long-term complications that we discussed earlier. Next, I want to talk about provider perception. This is from the same study as before, and as we saw in that study, men and women were equally likely to believe that their symptoms were heart-related. That is different for providers. Providers thought that women's symptoms were not heart-related in around 53% of cases, compared to only 37% of male cases, which means that even when men and women have similar symptoms, providers are a lot more likely to think that men's symptoms are heart-related compared to women. Similar to patients, providers are also more likely to think that women's symptoms are related to stress and anxiety. This a study found around a 10% difference. Patient providers were likely to think that 25% of women's symptoms were related to stress and anxiety compared to only 15% of men. So, in terms of misdiagnosis, which can result from incorrect provider perception of patient symptoms, 3% of men are misdiagnosed with myocardial infarction compared to 5% of women. And this difference may not seem substantial, but in over 50% of deaths from heart attacks, patients died outside of the hospital without receiving treatment. This means that every percentage difference in misdiagnosis counts because it can be a life or death situation for women to receive treatment on time in order to prevent long-term complications or death from heart attacks. The mortality rate difference between men and women is substantial. One study from 2016 found that after 28 days, a group of patients with heart attacks were tested. There was a 10% difference in mortality rate between men and women after 28 days. This percent difference increased a little bit in terms of 6-month mortality rate. So 6 months post the heart attack, women were around 11% more likely to die than men. So there's a couple of reasons why this happens. As we discussed before, patient and provider perception of symptoms can result in delays in seeking treatment and can also result in misdiagnosis, which can prevent effective treatment. There's also a couple of other reasons. One is biological. Women and men have different hormones, especially postmenopausal women, and these different fluctuations of hormones can increase the risk of heart disease based on age. The last thing is research. Uh, Even today, there are very few women included in research trials for medications for cardiovascular disease and heart attacks. And one study found that even with studies on mice, male mice are more likely to be used in research trials than female mice, which can impact how we view female symptoms of heart attacks because it means that we have less knowledge about them and therefore we're less able to respond to them. The last portion of my presentation is a few recommendations that could improve health outcomes for women. First is increased awareness. One study found that a lot of American adults are still unable to identify atypical heart attack symptoms. It was around 40% of American adults. This means that increased awareness about symptoms is essential for women to not delay seeking treatment and receive it on time. This is important both domestically and globally. It is important that we engage in global outreach programs to improve awareness about heart attack symptoms globally to ensure that women across the world are able to receive treatment on time after the onset of a heart attack. The second important thing that we could do is medicinal development. We can continue investing in treatments such as blood thinners that are specifically tailored to women with heart attacks to ensure that they have effective treatment that is able to treat the symptoms that they face as a result of heart attacks. Third is provider education. As we discussed earlier, providers also misperceive their patients' symptoms, and so it is important that we update providers' knowledge by including this knowledge on their test to maintain their certificate of practice to ensure that they are up to date with newer research on women's symptoms of heart attack specifically. The last thing that we can do, and perhaps the most important thing, is further research and making sure that we include women in global trials and surveys to ensure that we have an accurate representation of the population when we are making decisions that affect heart attack outcomes. So the key takeaways from this presentation is one, women have a greater likelihood of being misdiagnosed with heart disease and have higher mortality rates as a result. Two is that improving awareness among patients and providers is essential, and this can be done through improving research and outreach programs. The last thing I want to note here is that individual action is just as important as broader action. A lot of the time when we talk about broad issues that affect the globe, we talk about big organizations like the World Health Organization or the United Nations taking action, but it's important to note that individual action can improve awareness in our communities and still have a significant impact on reducing mortality rate from heart attacks, especially in women. These are my references, and thank you so much for listening. If you have any questions, please feel free to email me. I've inserted my email below. Thank you so much for listening. And I hope that all of you will be able to take something out of this presentation and hopefully make a difference in improving awareness to prevent negative impacts of heart attacks on women. Thank you.